I'm ready now.
Okay, 5 seconds.
Okay. Welcome, and thank you for joining us today for the meeting of the New York City Health and Hospital Strategic Planning Committee. Today's meeting is officially called to order. First, I would like to propose a motion to adopt the minutes of the Strategic Planning Committee meeting held on January 11, 2021. Anybody has any questions? Hearing none, I would like to take a collective vote. All in favor?
Yes.
Yes.
Anyone opposed? The motion passed. Thank you. Now we will turn the meeting over to Mr. Siegel. Matt?
Hello, everyone. Thanks for having us today. Excited to present to you our Q2 fiscal year 21 performance. This covers the period from October 1st through December 31st of 2020, which was the kind of part of our comeback from the first surge period and the beginning of our fall-winter surge period. So patient volumes declined through that period on the outpatient side, and that did have an impact across a number of measures. The updates now, the measures include the priority measures that committee members suggested and we updated with at the last quarter, and present a number of areas of both improvement and opportunity for further improvement. And then there are significant updates on the federal, state, and city policy sides that Deb Brown will speak to as well. Our other goals for the meeting today are to give a deep dive on our Mychart performance and our next steps on how we're going to be expanding that over the course of the coming year, and then to give a quick update on forthcoming metrics on our social and racial equity base of our strategic planning pyramid. So with that, we'll move to the next slide. And Deb, do you want to take us away?
Sure. Hello, everyone. Nice to see you all. As Matt said, there's a number of significant developments, and the way I've been thinking about these things is that they all sort of cascade, right? Particularly when you're talking about the financial support that we and many other organizations are seeking. As you know, since our last meeting, there was a passage of President Biden's American Rescue Plan, and that though that included no direct funding for hospitals, it did include state and local government funding, which was extremely significant when you think about it in terms of this cascade: federal money going to state, going to city, potentially coming to us. And so that, continues to be good news. And I will say, to the great credit, we have had previous packages that were specifically supportive of hospitals. I think that this one, as you saw, was a little bit broader, a little bit comprehensive, and there is a little bit of a concern, and we'll talk about this in a minute, that there's a consideration or a theory that hospitals are, taken care of. And that's something we continue to sort of push against at all levels. You will see, it's no secret, anyone who reads the paper, anyone who watches the news, despite the thin majority that the Democrats hold, there continues to be significant bipartisan rancor. And you're going to see that, I think, as bills continue to play out, as the Democrats seek to use the reconciliation process. I think this is going to show up in many ways. Obviously, the next big consideration is the infrastructure package that President Biden and many others have been speaking about. It's no surprise, again, for those of you who follow the news, the debate is really what constitutes infrastructure at this point. We, and fortunately many of our colleagues around the country, individual hospitals as well as associations, are really pushing for the inclusion of hospital needs as a component of infrastructure. And, I don't think that's a word game. I don't think that's something kind of cute or coy. If nothing else, this pandemic has shown us the need for ongoing, strong, resilient building. So that's, very much the focus of current federal advocacy. We are, of course, very fortunate to have Majority Leader Schumer, to have Senator Gillibrand, to have great representation from our House of Representatives folks who represent our hospitals. Sorry, tripped over that one. Especially important is Congresswoman Yvette Clarke, who sits on the Energy and Commerce Committee. We've been working specifically with her office and are very, very grateful for their support. And I think the last piece on the federal is, as people are taking their seats, as we are seeing, the secretary in place, as we are seeing the secretary's team come into place, we'll have a chance to delve into some of the policy regulatory issues that are, potentially divorced from just payment, I will say, but of course have a significant impact on our work strategically and financially. So these slides, moving down to state, these slides were clearly done a few days ago. We did reach a conclusion on the state budget. There was an email sent out to the board over the weekend. Happily, we and many other hospital colleagues were successful in deterring significant cuts. As I've said previously, the cuts that we were talking about would have had about a $250 million impact on our system. Thanks to, I want to really call out Michelle DeBacco on my team, who lives in Albany, is a creature of Albany in the nicest possible way, and really organized our strategic advocacy starting way back last summer. Early fall was when we first started doing meetings. But we and others were able to push off an across-the-board Medicaid cut, what would have been a very significant elimination of the public ICP or indigent care pool. There was, to a conversation we were having previously, Penny, there was a continuing capital cut, fortunately for us, that is of relatively minimal financial hit. I don't want to ever suggest that a few $1 million isn't important, but relative to the $250 million impact that would have come, that was really meaningful. I think what we will see, for those of you who are kind of familiar with the Albany session, is now post-budget, we will be dealing, until, until the end of the session, with a series of programmatic bills, policy bills. So I guess the point is we will continue to be sort of in there fighting. As we do, we are fortunate to have many allies, actually in chambers, at the Department of Health, and certainly in the legislature, who are working with us in a number of creative ways. If you could go to the next slide. Thank you. I think that, the big issues, not surprising, with the city is sort of understanding how this administration will seek to use its resources and its leverage in the remaining months, how this administration is going forward with many of the legacy items that are so important. And we've been very fortunate, H&H has played a significant role, and we are very, very well positioned, I think. Of course, there are going to be budget constraints, so we're sort of in the midst of the city budget process. Went through an initial preliminary budget hearing with Dr. Katz, with John Ulber, with a number of my other colleagues. Went very well, fairly uneventful, which is a good thing. But we are, of course, looking at mayoral changes, many changes in the council, borough presidents, DAs. It's kind of a popping time in terms of New York City elections. And of course, healthcare is extremely important in all of that. So it's, really interesting, and I think important for us to be tracking the health platforms of many of the mayoral candidates, who are largely, sympathetic, supportive of us, understand the need for public hospital system, understand the issues of equity that we work through every day. But that will be, I think, the rounding through the next 6 months, this will be extremely significant for the system. And then just one, last thing to add is we, of course, always work with our communities through our community advisory boards, through the many, advocates and champions we have in the community. I do want to thank both the community advisory boards and our advocates, for the important role that they played in the budget advocacy at the state level. They were instrumental partners, as always. And I think one of the things that we have seen, and this is completely appropriate and, positive, is more and more of an outcry or a request from communities for services. And I think you see that in specific geographic pockets. I think you see that in, from groups that previously have not felt represented. And so, our community work gets kind of bigger, stronger, tougher. I don't mean tougher difficultly, but, more muscular, I would hope, as we seek to serve all of these community needs. I'm happy to answer any questions.
Thank you, Deb.
Thanks, Deb.
I don't know if there is any questions from the committee members.
I just
Sally? Sally, I think you're muted.
about that. Under the state item, you had nursing home focus.
Oh,
State of Albany. Were you talking about the governor's issue with the nursing home representations or something different?
thank you for asking, Sally. Well, what I was really talking about, though it's difficult to divorce them, is there were nursing home provisions in the budget. And what had happened was in the executive budget, the governor's proposed executive budget, there was a whole spate of nursing home provisions and nursing home mandates. And that was another area where not just we, but there was a great deal of industry kind of pushback advocacy to make a more rational sort of plan for the nursing homes. I think that's going to be an issue that we're going to continue to see post-budget. But that was really what I meant. But of course, you are exactly right, Sally. That is completely coupled with what has been going on in the press.
Okay.
Thank you. Frida, you have a question?
It's actually just sort of dovetails on that question Sally had, Deb, and congratulations. I mean, this is all good news. But the third bullet you didn't really touch on either, advancing H&H strengthening. Yeah. And I wondered if, and this kind of goes to my question of, we sort of dodged a bullet this time, but are these things that are were many of these proposals ones that you anticipate will come back up next year, or?
No, it's a great question. And, part of the strengthening is, as I said, because we have been working with chambers, with the Department of Health on, many arrangements to continue to better serve our populations as well as strengthen us. That was really, what that was really what that bullet references. And this actually goes back to last year's budget. We've been doing, work since that time. It's a great question. And yes, many of these things do always continue to recur. I don't know, it's been interesting this year. Of course, the concern initially was, oh my goodness, even before COVID, there was concern about significant, several $billion state deficits, particularly tied to the Medicaid budget. So that was where kind of the first notion of across the board cuts came. Then, of course, COVID came. Then there was this influx of state funding. So, federal funding to the state. So really the issue is going to be, what is kind of a one shot, which will help stabilize the state, and then what we are going to have to worry about going forward. There was, part of the state budget conversation was there are many advocates who are seeking to get rid of the Medicaid global cap entirely. That was not a successful area of advocacy for them. But I think the rethinking of how we structure our Medicaid program, how, the financial inputs to the Medicaid program continue to play out, that's something, that happened well before COVID and is going to continue to play out after COVID. And often that does, manifest in proposed cuts.
Right.
Thank you, Frida. Jose?
No questions, thank you.
Dr. Katz?
No.
Any comments?
No, thank you.
Thank you. Matt, back to you.
So, thank you. So I know the board's schedule is crowded this morning, so I will move quickly through this, and I'm happy to answer any questions. I'd say overall we had a number of very positive trends, some negative trends. The key story of this for me is the unpredictability and challenge of in-person visits in a period where we are approaching and moving into a COVID surge. So that's sort of the telling external factor for me. We have a number of fewer low acuity ED visits, so we have fewer patients leaving without being seen. Had some good results on inpatient care experience. and our Mychart activations have really soared, which is a tremendous success this quarter. Next slide, please. Because of the case mix index we've experienced and the timing of some of the federal relief, we had a very high ratio of revenue to expenses, which is excellent. Continued to make progress on our enterprise resource planning initiative. E-consults have continued to rise, as have our NYC Care enrollment. For some of these where we've dramatically exceeded the target, we tend to update our targets for these at the start of the fiscal year. So that will be our next meeting in July. We will have updated targets on several measures to go over with the board. Next slide, please. Again, on the negative trends, I'd say they all are very tied to the decrease in in-person visits, right? We were at close to 100%, I'd say, in 2019. At our best facilities, we got up close to 85, 90% in person over the summer into the early fall. But with a lack of in-person visits, I think it has been challenging to have those follow-up appointments, and our diabetes control measure, I think, has been slipping and may continue to slip, but we are taking aggressive action on that with pharmacy hires, other extensive outreach to bring people back in and follow up for those visits.
Can I quickly ask a question on that, on one of those? The follow-up appointments kept within 30 days. At all of our QAPI meetings, the hospitals are so far, the numbers are just so low. And I'm wondering whether this is a federal requirement, or if we impose it ourselves, whether we should either decrease the number as a target or see what efforts need to be made to get closer to the target. It's a figure that I don't even remember any of the hospitals coming close to that 66% figure.
Right. I think that is true. We had some success, I'd say, back in 2019 is the closest I remember getting up to it. It's a kind of well-endorsed measure. The 66% threshold may be too difficult for us. I think we can revisit that with our performance improvement and quality assurance teams. But it is as a measure itself, managed care plans, CMS, the state across the board do look to this one, and I think it can be an important measure for us of how we are succeeding people connected to care. So we'll look at the 66%, but I take your point. It's been a struggle in recent months, definitely.
Well, actually, yeah. Okay, it's fine. Thank you.
Thank you. I'm just following up on Sally's, and I know that we are very tight with time, and I'm not practicing what I'm preaching, but this may be a metric that it will be good to show the benchmarking, how other systems that have similar characteristics to us are meeting before any change of the target. Because since, as you're saying, this is a measure that is looked closely by external stakeholders. If one were to consider changing the target, I think it would be good to see what the benchmarking is against similar peers, hospital system.
Absolutely. We will pull that together for the board at our next meeting. Definitely.
Okay. Since we already, Sally and I asked questions, Frida, do you have any questions?
Just a couple. If we go back to the patient care revenue as a percent of expense, I like the positive trends. I just want to, and I think you might have said this, so the 72.6 is largely due to, say, this includes the CARES revenue, right, as part of in the revenue number, and then obviously we had a higher case mix index, et cetera. But that trend is sort of an anomaly? Would you say that, Matt, or?
I think it has been going up quarter over quarter, really, for the last 2 years. We have not seen a jump like this at any point in that time, which is, I think, driven by those one-time factors.
Okay.
But overall, it is our most global measure of our financial performance. And the CARES Act funding, I think, was we try not to include supplemental Medicaid or other things not tied to actual patient care experience. The CARES Act funding, of course, was tied to the sheer volume of COVID patients we had, and so it was, included in here. But
and Matt, aren't our expenses also artificially high during this period? Actually in the second wave, because we weren't able to draw nursing from other places in the country, we really had to pay a premium on the nurse registry in order to have ample staffing. So the expense part is also an anomaly. So it may be that we come out okay.
Right.
Our expenses are going to drop once we are through this next wave.
Yeah. Right. So it may be masking a lot of the other improvements, Mitch, that you're referring to, right? Because both things are elevated. Right. And there was one other question I had, Matt, is do you know if this patient care revenue includes the NYC Care dollars, or it does not?
It does, yes.
It does.
Yes.
Okay. And then on the next slide, on the negative trends, on the post-acute care, all-cause hospitalization, that's a new measure. Do we have a target for that?
I will have to check on our board.
So the rate's going up from last quarter, but I didn't know what our target was.
Let me get back to you on that one,
Okay.
Frida. I apologize. Yeah, I don't believe they've set a target for it yet, but we'll certainly have one at the next meeting.
Right.
Will it be possible to have it? Okay. Before we submit it to the board, so it would be. You think that will be possible for this month's board meeting?
We can certainly speak to Maureen and the team about it. I think they may have been looking to baseline it as in their initial submissions, but happy to work with them on what their target should be and try to include it before it's at the full board meeting.
Okay, thank you, Matt. Frida, any other questions?
No, it was just sort of talking around that, but I think maybe we'll wait till we have more data and information on that and about what's going on there. But
thank you, Frida. Jose?
Oh, thanks.
Okay, Dr. Katz, any comments?
No, I'm wondering if that's affected by COVID. Right, because when we have, nursing homes where you're talking Q1, and nursing homes, that was the period of time when so many people got sick in nursing homes and they would have gone to the hospital.
I think it is tied actually to one kind of cluster of admissions in November, actually, that drove this particular one.
I see, okay.
Yeah.
okay.
All right.
Thank you.
We have one more slide of negative trends just to look at. Again, I think tied to the in-person visit percentage. The percent of our uninsured patients who were counseled and enrolled in insurance coverage, NYC Care, or other financial assistance did drop. I think the number of our in-person counselors who can talk to people, is challenged by people having more televisits and things, but we are hoping to see that bounce back. The percent of MetroPlus's spending at health and hospitals dipped quarter over quarter. We did have that spike, I think, as the percentage of MetroPlus's other private contracted partners dipped over the prior quarter, which was the summer. And then I think rose back up for them in the fall. And of course, the ratio of our expenses to theirs drives that number. And similarly, I think AR days and unique primary care patients were clearly affected by in-person visits and the ease of follow-up. We will have an update on primary care patients seen at the next board meeting. There's been a slight look at change at the methodology there just to make sure we are not capturing anybody with coming in for just a COVID test in a primary care clinic. So Dr. Long and the team will speak to that at the July meeting as we update it and give you quarter over quarter trends over the past several quarters. Beyond that,
Can I ask a quick question?
Yes, Sally?
I promise it'll be fast. This percentage of uninsured patients confuses me a little bit. Maybe you can help me. So uninsured patients that were enrolled declined, but this was despite the inclusion of New York City Care insured patients?
Right. So in the prior quarter, 61.4% of the patients who came in without insurance or NYC care ended up enrolled in one or the other. In the fall quarter, a smaller percentage of the patients who came in uninsured left our care insured or in NYC care. So I think
just wonder how we still have a significant number of uninsured patients that aren't eligible for New York Cares or one of the managed healthcare plans. I mean, who
Right.
would they be?
I think it is typically people who, for whatever reason, we either are not able to spend the time with to counsel them on their eligibility, or who refuse to have that discussion. So they should be eligible. Everybody should be eligible for one or the other, right? So the goal here, theoretically, we could get to 100%.
Right.
It's more a measure of our workflow, our ability to make sure those folks get the counseling that we would like them to have to make sure they're enrolled in what they're eligible for. So that's what it comes down to.
There's a little bit of outside New York City, right? So especially the FQHCs by mandate, like the ones in the Upper Bronx have to accept people from Westchester. So that would be one group. There are also people who have private insurance who, for whatever reason, don't wish to disclose that. And we try as hard as we can, but people have various reasons for wanting their insurance companies to not know that they have certain conditions. And so that's a second common reason that I think people you'd think, well, they'd either fit in the insurance or they'd fit in the group. They won't give you the interview because they don't want to admit that they have another form of insurance.
I see. Okay, thank you.
Matt, just on that point, there's I think what I'm hearing is it's a little bit due to not being able to screen the patients, but I thought that it says here screening rates are approaching or exceeding the target, which leads me to believe that we're talking to them, but we're not getting them enrolled. Is that?
I think that is true, right? And I think the ability to complete the enrollments over the phone, right, for people who are having telephone and video visits is a challenge. And then I think so that kind of completion and actual enrollment is the barrier.
I see. Okay.
Okay, Matt, yes,
yes, sir. We have two other, again, new measures that are basically a steady trend. Our post-acute accounts receivable days remain relatively steady, and then we have our new measure of total wellness encounters that we have just begun counting on and collecting. We'll have a trend for you at our next quarterly meeting.
Matt, following up on Frida's comments earlier, maybe it would be good to find out if there is a target for the wellness, since that's another new measure that doesn't have target, but there was a new measure that did have target. So if you are able to find that, that would be great, and have it for the school board meeting. Thank you.
Okay. Excellent. On our COVID measures, again, I think a good reflection of how involved and effective our system has been in responding to the crisis. During this period, we did over 1 million COVID tests. Our post-acute infection rate was very strong, certainly compared to the national average and the state average, and then a major role in vaccine administration. During this period, the percent of occupied beds was quite low. It inched up as the winter surge came in, but again, always remaining below the state's 85% threshold around our system.
I'm
And with
sorry,
that, we
I had just a quick question.
That's okay.
Go ahead.
Ted Long just reported that they were responsible for about 50,000 vaccines. Is that enrolled into our figures, whether it's the 100,000 or 200,000?
Not necessarily, Sally, because what the canvassers will do is connect people to the soonest appointment. They
Right.
basically, so it wouldn't necessarily have to be with us. Right, it could
Oh,
be
I
a
see.
TOHMH site or a state site.
Oh, okay.
Okay, and then Dr. Davis was going to walk us through some of the Equity and Access Council's work and how we are considering adding new metrics to look at our social and racial equity base of our strategic pyramid.
Matt and Dr. Davis, can
Yes,
you
sir.
just 1 second? Let me just check because we are moving from one area to another just to make sure that there's no other questions. Sally, do you have any other questions about the metrics?
No, thank you, Fanny.
Frida, do you have any question about the metrics? Jose?
No, thank you.
No. And Dr. Katz?
Nope.
No. Okay. Dr. Davis, please. Sorry for the interruption.
Sure, no problem. So very briefly, because I know we are pressed for time, but the Equity and Access Council, the goal of the council is to provide strategic direction for the development of programs and initiatives aimed at eliminating barriers, institutional and structural inequities, and to improve the health and well-being of our vulnerable and marginalized communities. So our work is organized into 4 work groups. The Evaluation and Monitoring Work Group uses data to measure our program efficacy. The Workforce Work Group is using initiatives to enhance talent diversity. Our Workplace Work Group is looking at strategies to promote inclusive practice. And the Equity of Care Work Group, which are strategies to eliminate racial and social inequities. Next slide, please. So in thinking about our metrics, we've been thinking about what we'll need to really drive the work forward. And some of our considerations include building a robust data infrastructure, which will allow us to create disease-specific queries that are going to incorporate race, ethnicity, and other social identity categories. And this will enable us to identify disparities. We'll also be establishing inclusion groups that will allow for staff to connect and collaborate, as well as supporting career growth for physicians from underrepresented groups. We'll be evaluating, and where appropriate, we'll be replacing race-based algorithms in our clinical care, as well as we'll be improving the accuracy and the reliability of the collection of race, ethnicity, language, sexual orientation, gender identity, and other disability demographic values in supporting our system's ongoing efforts to improve both the healthcare delivery and the healthcare outcomes. So these are all areas that we will be considering in thinking about our metrics. Any questions?
Thank you, Dr. Davis. Sally, any comments about the potential metrics that will be used by Equity and Access?
No, thank you, Fanny.
Frida? Jose?
Thank you.
Dr. Katz?
Nope.
My only comment, Dr. Davis, is that, since your council is looking overall at health and hospital system, to consider metrics have to do both with the contracting, like MWBE, as well as the personnel demographics, as we have seen in the Equity, Diversity, and Inclusion Committee. So that would be just a suggestion. Thank you, Dr. Davis.
Thank you.
Great, and next we'll have an overview of our Mychart performance, which has really exceeded all expectations, and we're going to build upon quite a bit over the next year. So Jeremy, Becca, you want to take us away?
Yes, good afternoon, everyone. My name is Jeremy Siegel. I'm the Chief Wellness Officer for the system, supporting the workforce wellness, care experience, and system performance improvement portfolios. On behalf of the core Mychart planning team, it is an honor and a privilege to present upon our Mychart successes, as well as our look ahead for you. As many of you know, Mychart is a patient engagement and tool for us to really make an easy, seamless experience for our patient populations that we serve to connect to our system. It aligns to all 5 of our strategic pillars and really is a pipeline to patient growth, but more importantly, enhance population health outcomes. I'd love to introduce my colleague, Becca Mclean, who's going to provide some overview in terms of our patient portal metrics and a look ahead as to accomplishments as well as projects that we are in progress with. And we'll speak toward the end of this presentation upon how we are aligning our mission, vision, and values to enhancing Mychart. Becca?
Great, thanks so much, Jeremy. Hello, everyone. I'm Becca Mclean. I work out of the Office of Ambulatory Care and Population Health on Mychart. So we all know that Mychart is our patient portal at New York City Health and Hospitals, and this gives our patients access to their health information 24/7. And using Mychart, patients can either test results, request and view appointments, track their medications, send messages to their doctor's office, pay their bills, and more. So to track our Mychart engagement and activation success throughout 2020, the Mychart Steering Committee established 3 core metrics. So this is the percentage of patients that are active in Mychart, the total number of Mychart users, and the number of times users of Mychart log into their accounts. So here's just a snapshot of our overall data for 2020, as well as where we stood as of late March at the end of Q1 for 2021. So hoping to gain a more comprehensive understanding of how our patients are using Mychart, the Mychart Executive Steering Committee has also added additional metrics to track in 2021. Reporting components are currently being built to track these metrics and embed them into our reporting processes to inform our system-wide initiatives, as well as our site-specific projects. You can just see them listed there at the bottom of the screen. Next slide. Great, so I'm also excited for the opportunity to share a snapshot of our Mychart projects completed in 2020 around staff and provider education, as well as patient engagement. So a few of our most impactful 2020 projects include working with our Office of Diversity and Inclusion colleagues to ensure that we have patient-facing Mychart guides for our patients that are translated into our top 13 languages, and also operationalizing Mychart video visits across our system during the ongoing pandemic, and establishing a dedicated Mychart helpline for patients to use if they have questions about Mychart or if they need a little bit of tech support. And on the right hand of the slide, I've just listed a few of our upcoming and in-progress projects to give folks a sense of what we're currently working on. And I'm just going to highlight a few here for the group today. So we're going to be launching our facility-based Mychart steering committees to assist in improvement efforts, working to identify and implement performance improvement projects with the support of the Mychart planning team. And those are going to be kicking off on May 1st, which is very exciting. And then we're also going to be, looking to continue to leverage Mychart to directly link our patients to virtual express care should they need. That's right within the app now, which is nice and convenient. And of course, using Mychart surveys to address our VBP care gaps, our Gotham adolescent engagement campaign, and updating our sites and patient spaces with new Mychart engagement posters as well. So that's just a few that I wanted to highlight for the group today, and I'll just kick it back over to Jeremy to add any additional thoughts or comments.
Thank you, Becca. Becca honestly is our internal subject matter expert, and it is truly a pleasure working alongside of you. So as we want to continue to improve upon Mychart activations, as well as userability for both patients, but also the workforce, we created 2 separate work groups. We have a patient engagement work group made up of a variety of different departments and disciplines at every touch point that a patient touches that might be able to engage in Mychart. And we also did the same thing for our workforce engagement work group made up of different providers of care, various levels of the organization to really help us understand how we can optimize userability on their end as well. In addition to that, what we wanted to do is revamp and restructure the enterprise-wide Mychart Executive Steering Committee, made up of high officials across our system, as well as various department heads and disciplines, so that we make sure that we have a unified and uniform approach and strategy for the system. In addition, you heard me mention the core Mychart Planning Committee. That's a way for us to be the conduit to make sure that all communication is not only robust, but that we're all on the same page in terms of our goals, missions, as well as initiatives. As well as we are now launching, as you heard, in the coming weeks, site-specific committees that are made up at the site level, making sure that our care experience officers, as well as other stakeholders and champions of Mychart, can work together. The great thing about Mychart is that it has incredible data that we can drill down to a service, to a department, and then to a provider. So it provides us a lot of opportunity to really do some PDSA cycles and improvement efforts to really engage our patients better with Mychart and to really make sure that it's an efficient and effective tool for all.
Thank you so much, Jeremy. Any questions from board members?
Sally? Sally, you are
Sally, I
muted.
think you're, oh, sorry.
The percentage of patients active in Mycharts, these are individual patients, went up from 875,000 at the end of 2020 to 1.3 million at the end of the first quarter of 2021. Am I reading that right?
Correct.
That's amazing.
Yeah.
And
It's
amazing. Does this include Gotham sites, H&H, long-term care facilities, everything?
Everything. That's at the system, whole system span. Yeah.
Fantastic.
Thank you.
That's it.
Thank you. Frida, any question?
Yes, on that, it is really amazing, and I think it's transforming, the way we do things. So it's terrific. I had a question on the averages, and this sort of gets to the point, a little bit the point of what Sally was asking is whether we can track that some of those activations are actually perhaps because of, say, COVID or vaccine, or maybe someone who came to our system but won't be staying in our system, and so. One, if you have a sense of that, it'd be great to hear, but also on the averages, is this just a straight average, like the number of users divided by the number of accesses, or do we actually track the average, an actual user and how many times they use Mychart? Do you know what I mean? The distinction that I'm trying to.
So I think to your first question, just kind of looking like, okay, is this huge explosion just from COVID, from COVID test patients, or like how many are truly our patients with a primary care physician in our primary care departments receiving care from us? And I wish I would have included that slide. I can send it along in the appendix for reference, but we did do a drill down into our primary care departments, and it was just astounding. Some of the numbers are actually higher by primary care departments per site. Just a real testament to our staff's willingness to talk to our patients about Mychart, and also our patients' willingness to engage in and use the tool, which is fantastic as well. So we have done drill downs in those numbers to look, for more meaning in the data, to see, what is the context that Mychart is really used in. And again, how can we leverage that to stay connected to our patients, to get them to utilize these tools and feel connected to our care too.
Right. That's
building. Sorry, I was just going to say, building off of what Becca was just talking about, we're creating our own Mychart scorecard that the Executive Steering Committee is going to be seeing on a consistent basis, and we're really drilling down to remove the special pathogens only visits, which would be the COVID testing patients and things like that, and begin to drill down even further in the primary care active patients to see where we have future opportunities.
Great. Yeah, that'd be interesting to see. Thank you.
Jose, any questions on Mychart? No?
No, thank you. Just great work.
Thank you. Thank you.
Great. Well, this is our overall view. As we went through the positive, negative, and steady trends, we will get you those updated targets for the measures without them thus far, and look forward to presenting you and updating on some of the targets in our July meeting. Anything else I can answer or we can discuss with the board before we conclude?
No questions? Any old business that we need to address? Any new business? Hearing no more questions or items of discussion, I would like to adjourn this meeting. Thank you, Matt. Thank you, everybody, for presenting. Dr. Davis, everybody, thank you so much for presenting. Thank you. Bye-bye.
Bye.
Thank you.